I would like to thank Dr. Coleman for inviting me here. It's an honor to give this talk here in the fall of New York. So what is the future of checkpoint inhibitor therapy in Hodgkin lymphoma? So let's review where is the current state for checkpoint inhibitor therapy. As we all know, PD-1 and PD-L1, PD-L2 pathway plays a very important role in Hodgkin lymphoma. PD-1 is an immune checkpoint receptor, and binding of PD-1 to the PD-L1, L2 on the tumor surfaces downregulates T cell function and lets the tumor escape the host immune mechanism. And one can design an antibody to block PD-1 or PD-L1 to block this pathway. So Nivolumab is a PD-1 inhibitor, and there was a trial presented by Dr. Yunus and published already, showing in patients who with Hodgkin lymphoma who progressed after stem cell transplant and progressed after brentuximab vedotin. In this trial, the overall response rate by the independent review facility was around 66%, and by the investigator was 73%. A CR rate ranging from 9% to 28%. And the patient that was no prior response to brentuximab, the response rate was 72% to 81%. And Pembrolizumab, another PD-1 inhibitor, was also tested in patients with relapsed refractory Hodgkin lymphoma. In this trial that we have presented, this was done in 3 cohorts of patients. One cohort was a patient who had progressed after stem cell transplant and subsequent brentuximab vedotin therapy. One cohort was a patient that were transplant ineligible due to chemorefractory disease. And another cohort was a patient that progressed after transplant but have not had seen brentuximab. You see here that overall response were roughly similar, ranging from 64% to 74%, and CR rate was in the 20 to 24% range. So based on these data, Nivolumab and Pembrolizumab were 2 checkpoint inhibitors that received accelerated FDA approval. And mainly for Nivolumab, it was for patients who have progressed after transplant and post-transplant brentuximab, or patients who failed 3 lines of therapy. And for Pembrolizumab, it's for the treatment of adult and pediatric patients who were refractory or relapsed with 3 or more lines. So currently, for relapsed refractory Hodgkin lymphoma, PD-1 inhibitors are reserved in this relapsed refractory population after multiple lines of prior therapy. So where can the future of this be? Well, let's review the current landscape. So prior to 2016, we have, for upfront treatment, mainly the standard of care in the US is ABVD. For patients that have relapsed disease to induction therapy, traditionally we offer a salvage chemotherapy such as ICE followed by transplant, or a brentuximab vedotin combo followed by transplant. And for the patient at high risk for relapse, there's a brentuximab consolidation strategy. And for patients that relapse after autologous stem cell transplant, one can use brentuximab vedotin salvage or novel therapy allo transplant. So 2016 was when PD-1 inhibitor were introduced and basically mainly used for patients that relapse after stem cell transplant. So where can we go from here with checkpoint inhibitors? So instead of having a crystal ball to tell you where things should be, I prefer to think of this as what are the questions remaining to be answered. For example, in a patient that failed a stem cell transplant, and we know that we can use PD-1 inhibitors, is a question that should they stay on PD-1 inhibitors or should they get PD-1 inhibitor and then move to allo transplant? Or should PD-1 inhibitors be used as single agent or be in combination? And then can we use them as a bridge to transplant or as consolidation post-transplant? And what about their role in upfront treatment and also other PD checkpoint inhibitors besides Pembrolizumab and Nivolumab? So initially, when the PD-1 inhibitor were being used and they were being taken to allo transplant, there was case reports of hyperacute GVHD and VOD and early death. So that put a warning, almost a stop on transplanting after PD-1s. However, Dana-Farber group published their retrospective series of 39 patients that received PD-1 inhibitor followed by an allogeneic stem cell transplant. And the results showed that the 1-year overall survival was 90%, and the 1-year PF is 74%. And the NRM was only 10%. So this is actually not worse or maybe considered even better than your traditional data with allo transplant. There was associated with this acute GVHD grade 3 to 4, 23%, and chronic GVHD 41%, and 4 out of 39 transplant-related mortalities. But again, this shows that PD-1 followed by allo transplant is safe and also feasible to do. What about for patients that just get PD-1 and did not follow with transplant? What do we know about the remission duration? So this is based on Nivolumab data. At this time the data was published, the median follow-up was relatively short, only 8.9 months. At that point, the median PFS was around 10 months, and the PFS at 6 months is around 76.9%. Okay. And this is the same set of data, but from Pembrolizumab, showing that, again, when this was first published, the median duration of response was around 8.7 months. What you see on the Swimmer's plot on this side is that a lot of red dots, meaning the patient have progressed, yet the black arrow showing that the patient are still receiving therapy. So even though the patient have shown that they have progression on scans by maybe growth of a lymph node, some of the patients were allowed on the trial to continue treatment and reassess later. And you see that PFS may not be, the traditional sense of PFS may not actually tell you what is the correct duration of response on the therapy. So time will tell. In the next 2 or 3 years, we should have follow-up data on the Nivolumab and Pembrolizumab experience, and also on the post-allo transplant data to see whether or not these patients truly need an allo transplant after getting PD-1. And it may follow the story with brentuximab, such that if you achieve CR, you could have a longer duration and may not need an allo transplant. Okay. Next, what are the logical combination partners with PD-1 therapy? So Nivolumab has been combined with brentuximab vedotin, and Ipilimumab, another checkpoint inhibitor, also has been combined with brentuximab. And there's trials ongoing combining PD-1 with other immunogenic agents or immune therapies. For example, Pembro plus AFM13, which is a bispecific anti-CD30, CD16A antibody for NK cell-mediated immunotherapy. And the phase 1 for that is ongoing. There's also a trial combining Nivolumab with TTI-621. This is a soluble CD47 receptor blocker, which is kind of activates the macrophage. So instead of acting T cell, activate macrophage. So another armamentarium in the immunotherapy realm. And there's also preclinical data showing that HDAC inhibitors may enhance the immunogenic response. And there's a trial ongoing with Pembrolizumab plus HDAC inhibitors. And also PD-1 inhibitor plus hypomethylating agent is also ongoing in clinical trials as well. So I'm going to show you some of Dr. Catherine Diefenbach's data. This is a trial she led through the ECOG Akron Cancer Group, combining brentuximab vedotin and Nivolumab. And I think this population was, majority of patients already had seen a prior autologous stem cell transplantation. So she showed that it's possible to combine the two agents without a lot of immune adverse events. Most of the adverse events you can see are, again, largely grade 1 and 2. There were a few grade 3 or 4 events. And some of the common adverse events were elevation of AST/ALT. There's, of course, sensory neuropathy associated with brentuximab, some nausea. There's some rash and pneumonitis seen. However, the data shows that this is a highly active combination. In this set of data presented of 12 patients, the overall response was 100%, and CR was 66%. And this is what you would expect to see of each agent alone. So based on this, you would think the combination is synergistic. Okay. Now, Ipilimumab is a CTLA-4 checkpoint inhibitor, and it has 2 mechanisms of action. It can reactivate the inactive T cells in the peripheral blood. It also can downregulate T cell inhibitory Treg cells in the tumor sites. So this drug has 2 ways of augmenting immunotherapy. In the same trial, she also looked at a combination of brentuximab vedotin and Ipilimumab. And again, in these 18 patients, she also saw a high overall response rate of 72% and CR rate of 50%. And this trial, this trial is ongoing, but currently she's trying to combine all 3 agents together and looking at the toxicities and efficacy of that. And we'll wait for further data from her study to inform us if you could do a 3-drug combination. Now, the same combination, Nivolumab and brentuximab, has also been done as a bridge auto transplant. And this data was presented by Dr. Herrera at ASH last year. And this was a bridge to transplant strategy. For patients will get 4 cycles of this, followed by autologous stem cell transplant. And again, in this data set, the adverse events showed that there were not a lot of grade 3 or 4 events. Mostly were grade 1 and 2, and this combination is safe. And it was typically the same adverse things you've seen with these drugs. what we did see was there appeared to be a 30 to 40% grade 1 to 2 infusion-related reaction that you would not expect with either drug alone. Okay. And again, this combination was shown to be efficacious as a bridge to transplant in this setting. The overall response was 90%, with a CR rate of 62%. Okay. Now, so those are combinations with Nivolumab and Pembrolizumab base plus brentuximab. We had started this trial in anticipation of knowing that if brentuximab gets moved up to the upfront setting, then we wanted a strategy that does not involve it in second-line setting. And we had learned from the solid tumor colleagues that you can combine PD-1 inhibitor with chemotherapy, and that can sometimes have increased efficacy compared to chemotherapy alone. So we designed this trial for patients with relapsed Hodgkin lymphoma after frontline therapy, and to use a PD-1 based salvage strategy. So this is a trial where they would get Nivolumab for 6 weeks, followed by imaging, and that they had achieved a CR/PR, they can get another 6 weeks of Nivolumab. At that point, if they were achieved CR, they can go straight to transplant without any chemotherapy. However, they have stable disease or progressive disease, then they will get a Nivolumab plus ICE combination. Okay. And this is modeled after our brentuximab plus or minus ICE strategy. And so this trial is currently ongoing, accruing patients. What about the role of PD-1 therapy after consolidation? So we learned from the Athera trial that giving patients consolidation therapy with brentuximab post-transplant had about an 18 months PFS benefit. However, it is a year worth of therapy, and patients do largely complain of peripheral sensory neuropathy after that. So the Dana-Farber group did a completed study using Pembrolizumab as a post-transplant consolidation therapy. The accrual is done, and we're eagerly waiting the data from that. And Alex Herrera at our center also started a different trial of following his idea of the brentuximab plus Nivo as bridge therapy. He's doing this combination as post-transplant consolidation. The benefit of this would be that we're cutting it from 12 months down to 6 months, so for patient convenience, and also we largely learned that the patient who developed neuropathy from brentuximab is usually cumulative toxicity. So hopefully with this strategy, you may alleviate some of that. And this trial is currently accruing patients as well. So what about frontline setting? The PD-1's combination therapy for frontline for Hodgkin lymphoma. Well, in adults, we can separate into early stage and advanced stage. In early stage, I'm going to talk about 2 study designs that are about to start. In the advanced stage, there is a phase 1 trial looking at ABVD combination Pembrolizumab. There's also a company trial led by Nivolumab, having window study, having patients treated with Nivolumab for a couple cycles, followed by ABVD. I'm not aware of trial right now combining AVD with brentuximab plus or minus a PD-1 inhibitor. Certainly that is, I think, a trial that should be done. And in the elderly population where we may not want to give aggressive chemotherapy, there's also a trial looking at the role of BV plus Nivo as a strategy. So this is in the adults early stage setting. Typically in the early stage setting, the goal is to maximize efficacy or minimize toxicity. So Stephen Park within the Accrue network is starting a trial using a backbone of AVD plus brentuximab, and followed by a resaging. After 3 cycles, if you're PET positive, you would take out AVD and add Nivolumab, then followed by consolidation. If you're PET negative, you would go straight to Nivolumab consolidation. And Michelle Fennell is going through with the North American Hodgkin Lymphoma Consortium, is doing a study with, instead of AVD brentuximab backbone, she's doing ABVD backbone, where a patient get ABVD for 2 cycles. If they're PET positive, they would switch to BV plus AVD, then followed by Nivolumab consolidation. If you're PET negative, patient would be randomized to BV Nivo or ABVD times 2 plus Nivolumab consolidation. And we're, again, eagerly awaiting the trial to start and the data from that. What about some of the other checkpoint inhibitors? So we know that PD-1 can bind to PD-L1 and that inactivate T-cell response. So both the antibody we talked about earlier, Pembrolizumab and Nivolumab, are PD-1-based inhibitors. Avelumab and Ipilimumab are PD-L1 inhibitors. So these drugs will actually bind to PD-L1 on tumor cell surfaces instead of the T cells. And the Ipilimumab data was presented at Lugano this year, showing an overall response rate of 42% and CR of 16%. So it appears that if you just block the PD-L1, you actually are leaving the PD-L2 and PD-1 interaction intact. And that may explain why the response rate seems a little bit lower. Okay. So the future HL landscape, well, we know where we have now and where we're headed. There are many questions to be answered, and only time will let us know whether or not there's more of a bigger role for PD-1 therapy or checkpoint inhibitor therapy in Hodgkin lymphoma. Thank you very much.